Thank you. Thank you, Professor Lee, and also Professor Chua to organize this wonderful meeting. Today, my topic is the laparoscopic surgery in cervical cancer. And we also want to talking about a little bit about what we have learned from the leg trial. And in 2017, we have annual meeting in Okayama. They have focused on laparoscopic surgery in endometrial cancer. They have more than 3,000 participants in Japan. And 2018, we have a APAGE annual meeting in Surabaya. We have an announcement about the for the statement for the leg trial because we found they have some bias in the leg trial. So we have more than 2,000 participants in Surabaya, Indonesia, to have this annual meeting and have a wonderful statement for that. And in 2019, we have focused on the cervical cancers, how to make have a higher survival in Chongqing, China. So they are also we have also have 3,000 participants in the annual meeting. So, but 2020, because of the COVID-19, we postponed the annual meeting to 2024. And this year, they got Yokohama annual meeting. And so they will focus on how to have a nose surgery and how to get the better and advanced laparoscopic surgery in this annual meeting. So we know cervical cancer is a global burden of disease. And the fourth most frequently diagnosed cancers, and the fourth leading cause of the cancer deaths in women. Fortunately, introductions of HPV vaccinations, so the early detection is possible. And so in the many countries, the early stage of disease have been found and be management by surgery, but in some way be by the radiotherapy. And we know that got the evolution of the surgery in the cervical cancer. And in the very beginning, in the 19th century, the radical hysterectomy with the complete bilateral pelvic lymphadenectomy is favored. But later on, we found they have such a lot of the morbidity, even have mortality. So therefore, they have an individualization treatment for the early stage cervical cancers. So in the early stage, we may retain fertility, so we can do in the radical tracheotomy. And to lower morbidity, we can use the radical parametrectomy or sentinel lymph node dissection, or use the nerve sparing surgery, or we use the minimal invasive surgery for have a quicker recovery. So, but they have affecting the parametric involvement. We can find they have a factor, they have involvement about the survival. It include the tumor diameter, they have a lymphovascular permeations, have a nodule metastasis, and they have depth of infiltrations of the cervix, and the age also the fact for the prognosis. Even from slide, we can find the small lesions, they maybe have no lymph node metastasis, but we can find the recurrence rate when you just doing the hysterectomy, simple hysterectomy, the recurrence rate will be have a 24%. But if we're doing the radical surgery, the recurrence rate will be have a 13%. So they have a markedly decrease in the recurrence rate. Even the survival, we can have the 85% in the simple hysterectomy and have a better on the class 3 radical surgery in overall 5 years survival. So we can find here the we can find the lymph node metastasis. No, lymph node metastasis is not means they did not have a cancer cell in the parametrium or in the paracopin areas. So the radicality is very important. But another thing is the morbidity rate is relatively high in radical surgery. They have a 84% versus 45% in the class 1 surgery. And also the patient with the survival rate in class 1 have a 74 versus have a 73 about 50s. So the high frequencies of the adjuvant radiotherapy, you just doing the simple hysterectomy, then maybe you need to have a 69% of the patient need to have an adjuvant radiotherapy. But if you have enough radicality, then just have a 55%, maybe they need adjuvant therapy. So we can find the radicality is important in obvious cervical cancers, and the minimally invasive technique such as laparoscopy or robotic surgery have emerged in order to reduce morbidity without compromise survivals. So we got achievement of the minimal invasive therapy in cervical cancers. In 1898, the Wisdens have the radical hysterectomy. And in 1993, I myself and Dr. Huang and the Nazas Keru performed the first laparoscopic radical hysterectomy in Europe, in American and in Asia areas. And in 1994, the Dr. Deschamps, they begin to have the radical vaginal tracheotomy for more conservative treatment for the cervical cancers. And 2003, I and Dr. Huang doing the radical parametrectomy for the cervical stump cancer. So we can find the advance of laparoscopic surgery make cervical cancers more easy and the quick recovery from the disease. And also year 2000, we have a radical tracheotomy, and 2012, we got a staging surgery for endometrial cancer by no surgery. So we can find the laparoscopic procedures is advanced and evolutions day by day, and make the patient have a better survival and a quick recovery. So why they can have a very quick recovery? Because of the laparoscope have a less trauma to the patients, and they have a less blood loss, and have a good quality of life later on. So here we demonstrate how to do the laparoscopic radical hysterectomy. These patients have a CT scan and significant. They have some paralymph node metastasis. So first of all, we have begin with the ICG injections, and then we open the space of a pararectal space and identify ICG positive lymph node, and to remove the lymph node first. Here is the obtuse lymph node, and also the inter-iliac lymph node have a positive sentinel lymph node here, ICG positive. So here is the uterine artery and the inter-iliac artery. So it is not the positive of ICG. So after the left side sentinel lymph node dissections, we begin to have a right side lymph node dissection. identify the posterior lip of the ureter tunnel, and also the identify early stage cervical cancer. However, they have a very famous report from New England Journal of Medicine, and they just have a comparison between the minimally invasive versus abdominal radical hysterectomy for cervical cancer. They found it. The minimally invasive hysterectomy for early stage cervical cancer, they have a lower rate of disease-free survival and have a lower overall survival. And also they have a higher rate of the local regional recurrence. So in the European Gynecological Oncology, the guideline have made changed. So the current ESGO recommendation regarding approach for the radical surgery, the minimally invasive approach is favored is no longer valid and shall be removed and replaced by open approach is the golden standard. So ESGO just follow this paper. So they have decided to doing the open surgery instead, the minimally invasive surgeries. But in our group, we found it. Our Chang'an Member Hospital, the Fang team, we got a statistic from the 2009 to 2014. We published the paper in the Taiwanese Journal of OB-GYN. Totally, they have 69 patients. The length of operation about 3 hours, and the follow-up date is the 96 months, and the recurrence rate is 0. Death rate is 0. So 5-year survival is 100%. So why they have a so difference? In leg study, 4.5-year survival in minimally invasive surgery is about 86%. In open surgery, is 96%. But in our group, we get a 5-year survival is 100%. It's compatible with the open surgery in leg surgery. So although scientists measure errors is not amazing, we totally agree that the surgeons and the hospital in this study should not perform laparoscopic radical anymore. In the study, the hospital in the study, and the surgeons in the study, they should not perform laparoscopic radical anymore. But in the minimal invasive therapy, for some hospital, they get a better outcome and they get a quality. They have a qualified surgeon. They can have their data and do the surgery. It's persistent. Otherwise, should we go back to laparotomy? Everyone of you using the iPhone, the weight of iPhone, just 162 grams. And do you know what's the weight of the traditional telephone? at least the 1 kilogram. So you know it's quite heavy, and it's not so smart. It's not intelligent. So they just can have a talk, cannot have a video, cannot have a cannot communicate face by face. So shall we go back to traditional laparotomy? No, because in the Surabaya, we got the some statement. We have found it have obvious bias in the leg study. So we have a statement about the clinical trial should be more rigorous. Why they should more rigorous? Because we found they have some bias in the trial. The APAGE hold different opinions, and the performance in surgeon is not standardized in the trial. And they have a very difficult in the standardization of radical in many countries, because some country is relative less. And the new instrument and the new concept in the image is very quick evolutions. And also in the study we found in a simple endometrial cancer surgery, they have 25% of convert rate from the laparoscope to laparotomy. But in the very difficult radical surgery, in a study, they just have a 3.5%. So we wonder, just like the slide we present before, there is a type 1 instead of type 3 radical, simple hysterectomy rather than radical surgery. So the recurrence rate will have difference. They have a paper in ESGO have shown already. So also we can find they are not so many surgery of the cervical cancer in some countries. So cooperation in training and education is necessary in worldwide, and is very urgent. And so owing to the obvious bias in the leg study, in the gynecologist should point out the bias and explain to patient and use the data from the qualified minimally invasive surgery center instead. So what's called the scientific methods? At the core of APAGE and other science lie a program sorting approach methods. So they have a 5 basic steps for the scientific method. First is make observations. Second is ask questions and form and hypothesis. Then make a predictions, and based on the hypothesis and test the predictions. So we can find this leg study. The leg study hypothesis that is right, but in the control group, we should miss the scientific test did not control in the conditions we have just need one or very few factors are changed, while others keep constants. In doing the surgical clinical trial, it did not like the giving some peer to the patients. That is a constant. In the surgical trial, surgeon is crucial, is most important in the trial. So we need to reduce the error in the biopsy. In the personal bias, there will be, because of the like or dislike, they always have a personal bias. But in this situation, we should interpret by different way, by different sense. So after the announcement of leg study, they don't agree to have another trial because they say it is illegal if we have another trial. But according to the science method, if there is a different result when compared with the most recent study, you should come back to revise the hypothesis and find out what is the difference in the trial. And for example, we have an obvious bias in the leg study. They have a 33 center worldwide from June 2008 to June 2017. 9 years and 631 patients recruit in the studies. So it means totally they just have a 2.1 patient per center per year. So every center, every year, one got minimally invasive surgery and one for laparotomy. For open surgery, maybe that's okay. But for the minimal invasive surgery, it's quite far away from confidence in doing the surgery. So another thing is the surgeon. You need to just have a 2 video. Then you will be qualified as a clinical trial principal in doing the surgery. So the surgeon's confidence is not good. Not the reason they have because of the potential reason for inferior oncology outcome is because of using the uterine manipulator or because insufficient gas CO2 inside there. It looks like that is right because of the compare with the open surgery. Open surgery don't use the uterine manipulators. They don't use the CO2. So you can have this hypothesis. But is that really? No, you even don't have any paper talking about the insufficient is difference. The pressures, the no pressures is difference. Even you can use in the gasless, the laparoscope. You don't use the comparison between the gasless laparoscopy or the open surgery or the traditional laparoscopic surgery. But you have a conclusion, the effect of insufficient of gas. I don't think that is right for a fine journal, just like the New England Journal of Medicine. So how to have reduce the error and bias? If you have find that have some bias or that have some errors, we shall have a repeating the experimental trial multiple times and recruit all data. And maybe you can use a persample, just like I have mentioned. You can use the gasless and compare with the laparoscope, or you compare with the open surgery, or even you can recruit the competent surgeon in doing the surgery, not just have a 2 video clip to have a identify they have a qualified in doing the surgery. So we can find a scientific method is an ongoing process. So make observations and thinking about the interesting questions and formulate hypotheses. Then we develop a testable predictions. And when we have a hypothesis, we shall have develop testable predictions. And then we make the test and then gather the test. And the test, when the results compare with the previous one, relevant data can be come from the literatures, not only your own data, but also the data from previous published in the journal. Not only your own data is right, the data from other doctors, they have more than 330 studies from the journal. We have published data about the systemic review and the meta-analysis in the 2019. So it's called the laparoscopy versus open radical hysterectomy in women with early stage cervical cancer. We recruit year 2000 to 2019. They have 30 studies. And totally, they make a conclusion. Laparoscopic radical in woman diagnosis is early stage cancer. Using the minimal invasive surgery do not increase recurrence rate or decrease survival in the 22 studies. And the mode of laparoscopic radical hysterectomy do not affect the negative prognosis and which drive for the adjuvant therapy. It means in doing the laparoscopic surgery, they did not increase the rate of the adjuvant therapy. And also in laparoscopic radical group, intra-op, the complication is similar. And the furthest, the significant low post-operative complication. So from the complication rate, we can find the laparoscope always better than the traditional laparotomy. And also the survival in the experienced surgeons in the data published now, they have even most of them, they have an equivalent outcome when compared with the laparotomy. So, and to our study, in our hospital, we have performed the laparoscopic radical from 1993. In the early stage, we have published the data, and recently we have corrected our data in 2009 to 2014 in the 69 patients, and we can find the data is quite different from the LEC study. They just have 86% of the 4.5-year survival, but we got the 105-year survival in our group. Why we can have a better outcome? We can get the 100% of disease-free survival in Chang'an Memorial Hospital because we just follow the Okabashi radical technique very strictly, and we may obtain the safety margins and use a traumatic uterine manipulators and keep concept of the tumor-free. Dr. Chua have talking about the uterine, about the concept of the tumor-free, not only in benign case, but also more important in cancer patients to keep the concept of tumor-free. And the flush with the presence of the lateral solution post-operatively, and the dedicated approach and the adjuvant therapy on time. That is all very important. Here mentioned again, the surgeon, the qualified, confident surgeon is crucial for the surgical clinical trial. In any surgical clinical trial, the surgeon is the most important factor. So we can find all over the world, the minimally invasive therapy for the cancer is a trend in the more than 100 cancers in all over the world, in all over the body. They have more than 100 cancers, except the leukemias, some should be medical oncology treats. Other, they should treat surgically. The minimally invasive is the trend for the surgery. But how come the cervical cancer is different? Is the cervical cancer is totally different from other 100 cases cancer? No, it's just like the empire's new cross. Everyone know the kin without crossing, but just the kin, they don't know. Just the gynecology oncologists, they don't know. They did not wearing anything. They just like a kin's new cross. They just like the empire's new cross. So that is different from gynecology to another, just the general surgeons, general pathologists. They're doing the minimally invasive as a routine, but just the gynecologist, they have concern about they should be go back to the traditional open surgery for the cervix cancer. Can you take the traditional telephone outdoor instead of the iPhone? Can you don't use the mobile telephone? You just use the room telephone instead. So it's very ridiculous for the gynecology oncologist. They have this conclusion. So why? But we don't want to bring them because they don't get the confidence in doing the laparoscopic surgery. So we should let them learn how to achieve better survival in the cervix cancers. It's very important. It's not an issue because we have published the data in the 2010s. We have from the very beginning in the still learning curve, in the looking for the long-term survival outcome for the laparoscopic assisted radical hysterectomy in treating early stage cervical cancer. We have 139 patients from 1994 to year 2005. And so the follow-up more than 9 years. And the 9 years, they have overall survival, have a 92.7% of survival. And the disease-free survival is 91%. So we get a conclusion. The laparoscope get a better outcome and a better life quality, but they should be performed by the experienced surgeon, and then they can make a better outcome there. So when the next study come, we have make another statistics on our patient in 2009 to 2014. I think that is Dr. Chua also have joined this study and the statistics about these patients. We can find every case is true. It's free of disease. Totally, they have 69 patients in the study. The blood loss just 250, and the length of operation about 3 hours, and they get 0 recurrence and no patient deaths. So the 5-year survival is 100% in the periods of the 2009 to 2014. And still now, they have a few more, the patient, they suffer from cervical cancer. But recently, we find the data is almost the same. They have a 100% of survival. So why can we have the survival in the laparoscopic radical hysterectomy? Again, we have some technique here. First, we have insufflation from umbilicus and use the leaf-on point forehand surgery method to make the surgery. So we can have a forehand surgery in the same time, and then we may have after the lymphoadenectomy, we begin to have a radical surgery. In this video, we just showed you how to standardization of the radical surgery and what is the tumor-free concept here. And then we also use the advanced instrument, use the ligature using the castles, the images to doing the surgery. So you can find here very clear the every vessel, interiliac artery here, and the uterine artery we have a calculate and dissected, very clear, and never bleeding after the calculations. So you can find the advanced instrument advanced instrument is very important for the laparoscopy surgery, and also the very good the camera system also very important. Here is parametric areas, uterosacral ligament. We have coagulated and dissected. So deep uterine artery and the band have dissected from the side wall. Okay, so here we can dissect the parametric at the distance we needed. In the type 3 radical surgery, we should dissect it from pelvis side wall, but we should free away from the hypogastric nerve and the splenic nerve here. So here is the hypogastric nerve have preserved, and so here is a parametric have been dissected. So after we have dissect this area, then the paraureteral space and the paravesical space have been unified. So here the ureter is there, the ureter is here. So here is the bladder, and here is the Laparoscopic areas. So here is the Laparoscopic we just resected. So previous slide I had showed you the negative parametric metastasis. That means they don't have a cancer cell there. Maybe they have the intratissue, they have some infiltration of cancer cells, but as the pathology result, they are free of metastasis. So in the cervical cancers, obvious they have a cancer there. We should have a type 3 radical, not type 1 radical surgery. So we use the monopolar to coagulate and dissect it. We use the ultramatic, the uterine manipulator to protect the uterus, and all the way dissect the vaginus and resect the tumor away from the pelvic cavities. So we shall have a standardizations of radical, and also we shall have a tumor-free. We can find cervix is enrolled in the probe. So the cancer is free of contact of the pelvic floor. Then we draw it back, and then we have a corpus lactate ringer to irrigations, and even we using the sponge to irrigate and have a clean all the cavity layer. Then we check the cervix and also vaginus and the Laparoscopic area. So that is very important. In the radical surgery, you should identify the preuretal space, parauretal space, paravesical space, and also the vesical vaginal space. So all the space should be identified, and the parametric and the Laparoscopyin should be removed adequately. So successful treatment for the cervical cancer should be include first, early detections of cervical cancers, and secondly, have a standardizations of the radical technique. And the third one, you should have a tumor-free concept. Then you using the advanced instrumentations, and you should give the patient adjuvant therapy in timely and appropriate methods. Because of the laparoscope, so we can have the adjuvant therapy in timely. If the patient they got a laparotomy, you will care about the dehiscence of the wound. You will care about the pain and the recovery of the bowel. So sometimes you will delay the adjuvant therapy. They have a compromise the successful of the treatment. Then we shall qualify surgeons in minimally invasive surgery. that is a very important for the item for the successful treatment for the cervical cancers. So we have showed you about the uterine manipulator. I think the blind-tipped manipulator and the blind colpotomy cuff insertion is very important. Just like the donate-type uterine manipulator or like a Makeshka, the Dr. Also our founder, one of our founder, the Makeshka Prashant Makeshka, they have another, the uterine manipulator is also quite helpful in the tumor-free the circumcision for the tumor for the cervix, and the space are retraced vaginally and intact. If you can make it intact, you shall close the cervix in advance, and after the surgery, copious the irrigations of the peritoneal cavity with the lingual lactate is also very important. And also, why tumor-free concept is such important? Because 2008, we got a paper that is the inhibitions of ovarian cancer growth and implantation for the chemotherapy after laparoscopic surgery in mouse model. In the laparoscopic surgery, we found in this side, we use the laparoscopic insertion and the air insufflation from G point and the cancer cell insertion from I point. And in the control group, totally, they get 93% of the metastasis on the wound or trochasite or intraperitoneous. But immediately we get chemotherapy, they have just 14% of them. They get some metastasis or they have a trochasite metastasis. But if you delay, they increased to the 71%. So in animal study, local regional metastasis or tumor growth were related to the tumor size, the tumor load, especially for the intraperitoneal tumor load. If you filter them, 200,000 cells will present no significant difference in wound metastasis or implantation when doing the laparotomy or open surgery. So that's the reason I'm talking about the leg study. Even don't have such a study, they say maybe a pneumoperitoneus can cause the poor outcome for the minimally invasive surgery. In this paper, in 2008, we have identified the metastasis and also the growth of the tumor is not difference in the pneumoperitoneus, but they have some meaning in the tumor loading. And if you have not enough radicality in the patient, then the tumor load, there will be more than 200,000 cells left in the pelvis. Then they get the implantation or recurrence very quickly. So in this situation, early adjuvant therapy may be quite helpful for that. And another is we use the advanced instrument because increased of the wound side metastasis and the recurrence of the surgery for cervical cancer can be attributed to the residual tumor cell load from inadequate, removed, or resect from the tissues. So advanced instrument is very important. And there I talking about the adjuvant therapy, we have a talking in timely. Okay, so we can find from the castles, they have a you want to have a sentinel lymph node, they get a luminal ICG. So near infrared, they can have a simultaneously have a wide rate and infrared in identify the sentinel lymph node. So they can have overlay system and not only green and blue, and they have a monochromic, and so they can very easy in doing the laparoscopy with the positive sentinel lymph node. Also, we use the advanced instrument, like sure from the Medtronic, they can have a very reliable the approximation for the basal. So they are not relied on the proximal thrombosis. They have a sealing on the basal wall. So they can have a resistance to the pressure up to the 800 millimeter mercury. So I think the advanced instrument make the success of the laparoscopic surgery in the cervical cancers. So the successful treatment for cervical cancer should include early detections, enough radicality, tumor-free concept, advanced instrumentations, and quite good adjuvant therapy in time. The last and the most important things is qualified surgeon in a minimal invasive surgery center, qualified surgeon in the qualified center is the most important of this, the treatment. So this is a famous Massachusetts General Hospital from Harvard Medical School. The comparison between the minimal invasive therapy with the open surgery, 100 and 282 patients from year 2000 to 2030. We can find the minimal invasive radical surgery do not compromise the patient overcome the outcomes, and the overall survival rate, recurrence rate, and the pelvic lymph node dissection or positive rate. The minimal invasives did not compromise. And the betas in the minimal invasive surgery include mobility decrease, is estimated blood loss decrease, and the blood transfusion rate is decreased, hospital stay decreased. Also, the recovery is decreased. In the good, excellent endoscopy center, the results is quite different from the leg stride. So I totally agreed. In the study of leg, the hospital recruit in the study, they should not perform laparoscopic radical surgery anymore. They should not perform laparoscopic radical anymore. But in the center, they got the experience in doing a radical surgery before, and they get a better and even good outcome. They can continue to perform the laparoscopic radical surgery. But why is there a misunderstanding? Minimal invasive treatment cannot apply on gynecology oncology. I have been talking about all the surgeons. They all agree with doing the minimal invasive in cancer surgery, except the gynecologists. They have some exception. Is cervical cancer is totally different from another 100 cancers? No, there is a difference in concept because insufficient training and education for the minimally invasive therapy. So in this situation, it's just like the bride led the bride. So there is a very dangerous as the bride leading the bride. And the public is not well educated. So it's very easy, but maybe have a very easy to be misled. And all health incidents, patient knowledge and experience are priceless. So maybe just perform the open surgery. The payment is the same, and also fail in certificate and the training system in the endoscope surgery. So there is a way, some way to reduce the error and the bias. So repeating the experimental trial multiple times is very important, not to stop the surgery or not to stop the trial. If you stop the trial, it's illegal. Doing the trial is legal, you know. So it's not such a announcement for some surgeons. You say we should not do any cervical cancer trial because the data have shown minimally invasive have a poor outcome in this 33 center. That's right. In the 32 center, they have a recruit in the study. They should not perform the radical surgery by laparoscope anymore because they get a very poor outcome for that. But just in the Harvard University Hospital, Massachusetts General Hospital, they have a better outcome. Just like Chang'an Memorial Hospital, we get a better outcome. We shall have a repeating the experimental trial. Then that is much legal. So we initiate APAGE, the MITRE study, the minimally invasive therapy versus open radical surgery for that. And before clinical trial, we have a certificate. The principal investigator include the doctor from the United Kingdom, Fugman, right, and from the Children's Hospital, and Michel Canis from France, from the Center Hospital University, and the Peter Lin from the United States, and Dr. Kano from Japan, and Masaki Endo from Japan, and Android from Brazil, and also TJ Kim from the Koreas, and I myself, Dr. Huang, Dr. Chen, Dr. Lin, and also the Aranya, and also the Dr. Suresh from India, and some doctor from the China. Also, we offer the training program every they have a course of the 3 months, and they got 2 radical surgery every week. So the surgeon, they can have a very good training of the radical surgery, and they have teaching you how to have enough radicality in the cervical cancer surgery, and they have also have chance to as the first the assistant in the training system. So APAGE organize this standardization of the laparoscopic radical hands-on training in our website, but because of COVID-19, the programs just interrupt. Previous week got several doctors already to have a training program already, and then interrupt by the COVID-19. But after COVID-19, the standardization of the laparoscopic radical hands-on will be continuous. So I think if you are interested in the treating the cervical cancer by laparoscopy, then welcome you to join us. So lastly, they have a take-home messages. The specific measures is the scientific methods is ongoing process. One step is long, and each of following steps will be long, just like leg try. There's just one step is wrong. What step? The step is not qualified surgeon and not the standardization of the radicality. So the countries and the surgeons, they make some difference between the radicality. So from the paper, we know the simple hysterectomy, the outcome is quite different from the class 3, the radical surgery. So the one step is wrong. Then the gynecology, oncology, quite different from another surgical oncology treatment. compared with the pathologist for the colon cancer, for the gastric cancer or thoracic cancer, that is quite different already. And the performance in surgeon is crucial in the surgical clinical trial. I think that is the most important, especially it's not the given, just like COVID-19, we use the phases or we use the AG, the vaccinations. That is the simple, the single dose of simple, just give them medications. The surgical clinical trial that depends on the confidence of the surgeon. So the clinical trial should be very vigorous, just like the mitral study. If you want to join the mitral study, you should be qualified in the very beginning, and not surgeon be qualified, but also the center should be qualified before you join the trial. And the standardizations of the radicality techniques is important in the disease-free survival. And the tumor-free concept is very important because of local regional metastasis, not because of the parametric involvement. They have some metastasis already in the cancer cells. Maybe they have some cell load layer, because the number of cell load is very important in the tumor, in the recurrence. So tumor-free concept, enough radicality is very important. And the early detection, standardizations, tumor-free concept, advanced instrumentations, and the adjuvant therapy in timely. And the most important is the qualified surgeon in the qualified center. That is the is most important. And so, because of cervical cancer is a rare, getting rare, so the cooperation in training by APAGE is very important. We will cooperate with the European Society and also the American Society. And in cervical cancer, minimal invasive therapy should be performed by qualified surgeon. Afterwards training, the 100% 5-year survival is achievable. So owing to the obvious bias in the LAC trial, we suggest that gynecology should point out the bias of the LAC trial. Why is planning the patient or using the data that is a qualified minimal invasive therapy center instead? So be a well-trained endoscopist, not just a half-trained, just like the Shivavinius and also the Dr. Chua. It's a well-trained endoscopist. Congratulations. And welcome to submit your paper. We need to have some more data here to have to make everyone know about the minimal invasive is good in gynecology. The impact factor of the GMIT is 1.3 this year. Thank you for thank you for your contribution in this journal. Dr. Tra also contribute a lot, and the Silvervinius also, and Azula also have a contribution in this fine journal. Lastly, I welcome you to the 2022 APAGE annual meeting in Taipei. Welcome home again, every one of you. Thank you for your attention.